Most of the topic has already been discussed since morning. Early esophageal cancers like stage 1, T1A and T1B, or it is stage 0. Histologically, it includes common cell carcinoma or adenocarcinoma. Management of early esophageal cancers is based on the patient or the tumor characteristics and the available institutional expertise. And the multiple options we have is endoscopy, surgery, or chemoradiotherapy. The Japanese classification, they have devised T1A and T1B. T1 is a primary esophageal cancer within the mucosa, intramucosal, irrespective of lymph node status, metastasis. T1B is divided into SM1, SM2, and SM3. That's the upper one-third, SM1, middle one-third, and the lower one-third. And the classification is based on the specimen of surgical resection. Endoscopically, SM1 is defined as infiltration up to 20 microns. But SM2 and SM3 have been undefined. So coming directly to the endoscopy for early esophageal cancers. As I said, its indication is for T1A tumors, which is mucosa with no submucosal invasion, and in select T1B cases. It involves endoscopic mucosal resection or endoscopic submucosal dissection. EMR is for superficial tumors. It's suitable for local focal lesions. And ESD for a deeper or a larger, deeper mucosal lesions. Lesions which is more than 15 mm, they're poor lifting tumors, and there's a risk of submucosal invasion. Evidence shows that endoscopy is effective for T1A, which is high complete response rate, around 90 to 100% for dysplasia. It has low complication rates. The perforation is less than 5%, and American Society have suggested that EMR plus ablation can be curative for very early T1 cancers. Advantage of endoscopy is minimally invasive. The organ is preserves the esophagus as an outpatient procedure. Limitation, endoscopy is not suitable for T1B with lymph node risk and requires close follow-up. The various studies is one at 2014 PET endoscopic versus surgery for T1 adenocarcinoma. A comparable 5-year survival was 90% compared to surgery, and endoscopy showed lower morbidity, and they showed lower morbidity with endoscopy. Then American Society, they have combined EMR plus radiofrequency ablation for Barrett's esophagus with high-grade dysplasia. Here they had complete eradication of the neoplasia, it was about 96%, and complete eradication of intestinal metaplasia, about 89%. Another study, Kodama et al., they have used endoscopic ESD for superficial squamous cell carcinoma, T1A. Here that en bloc resection was 95% and R0 resection was around 89%. The 5-year disease survival was 98% for mucosal SSC. But they have adverse reactions, like as for strictures, Stepper's EMR, or there's 15% in ESD, and there's bleeding or perforation. So endoscopy is best for T1A tumors, elderly, and patients with comorbidities. Coming to surgery, indication is T1B tumors. Some T1A cases in healthy patients who have high risk features like polydifferentiated lymphovascular invasion. In those cases, T1A cases can be done. Technique is esophagectomy. It could be minimal invasive or robotic. The evidence is high R0 resections are achieved. There's complete tumor removal, about 90 to 95%. The 5-year survival for T1 cancers is 70 to 80% with surgery alone. But there's high morbidity versus endoscopy. Surgery is high morbidity. We have complications like pneumonia, anastomostic leaks. Advantage is a definitive treatment where the lymph nodes are removed. But limitations are, as I said, surgery is invasive, a longer recovery, and impacts the quality of life. Health-related quality of life is impacted.